गुड इवनिंग शर्मा सर।
गुड इवनिंग हिरेन भाई, गुड इवनिंग। कैसे हो?
वेरी वेल सर, हाउ आर यू?
Good evening. Good evening.
गुड इवनिंग सर।
Welcome.
गुड इवनिंग गौरव सर।
Yes, sir is opening batsman this
ही
time.
इज ही इज द बेस्ट
Yes.
फॉर
चीफ
पीडियाट्रिक
सिलेक्टर
यूरोलॉजी।
चीफ सिलेक्टर मैनेजर ने बना दिया जिसको ओपनिंग बैट्समैन, वो ओपनिंग बैट्समैन।
So
कैप्टन ऑफ द टीम।
we just wait for 5-7 minutes. थोड़ा हो जाए ना।
हाँ हाँ
गीते
सर।
सर को और मैंने महेश्वरी को फोन किया था पर
हाँ।
दोनों ने उठाया नहीं है. I hope they get the message properly. हाँ?
अरे सर मैं
आ
हूँ।
गए?
सर इज देयर सर
अरे आ
ऑलरेडी।
गए. वाह.
पंकज लिखा है।
अरे
सर
वाह, मैं देखा
महेश्वरी
नहीं.
सर फोन नहीं उठाते, वो डायरेक्ट आ ही जाते हैं।
नहीं फोन आए नहीं सर, आपने कोई गलत नंबर पे रिंग लगा दिया। देयर इज नो मिस्ड कॉल। लेट मी चेक
नहीं.
अगेन। अरे हाँ सर, ये अब कल था।
वो शर्मा जी ने बोला ना, आप डायरेक्टली आ जाते हैं।
आ जाते हैं. Good, good. We just wait for 5 minutes and then we start.
श्योर 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 सर।
Yeah.
गुड इव्हनिंग डॉक्टर गीते.
गुड इवनिंग सर. गुड इवनिंग सर.
कसं चाललंय?
गुड इवनिंग सर।
फिलहाल तो चल रहा है सर. कल अहमदाबाद जा रहा हूँ एक्चुअली.
कैसे?
सर
पेंड्रिकॉन के लिए.
ट्रेजिक।
अच्छा पेनिकॉन के लिए, हाँ हाँ हाँ। रियली सच अ ट्रेजिक थिंग टुडे.
या वेरी
Yes,
सैड,
yes.
वेरी सैड। Some people are saying bird strike, but we don't know now. Investigation.
सर लेकिन वो अपने यूजी हॉस्टल पे गिर गया सर वो.
है ना?
Yes sir. Yes
Very
sir.
bad.
सर
Some
ये बर्ड
interns.
स्ट्राइक से अगर प्लेन को इतना नुकसान होता है, ये पहले बहुत होता था, तो बर्ड्स को ही ट्रेन कर देने का कि भाई जिसके एनिमी का प्लेन है उससे जाके टकरा जा। इतना सब टेक्नोलॉजी में ही नहीं डालने के।
नहीं, सरप्राइजिंग क्या है सर कि दोनों इंजन एक साथ बंद हो गए. वो बड़ा डेंजरस है क्योंकि एक इंजन बंद भी हो गया तो दूसरा इंजन पे काम बनता है सर यूजुअली.
You have seen that movie Sully, no sir? In that both the engines failed.
Yes.
That it's a real story where he landed on the Hudson River.
क्या है वो डेस्टिनी बोलना, दूसरा क्या कर सकते.
Yes sir.
शर्मा सर बुक मिल गया, बताने का
Yes,
रह गया
sir.
था मेरी तरफ से.
अरे नहीं
थैंक यू.
सर, वो मिलना ही था। नहीं नहीं, वो उसने सर, पब्लिशर ने सबका एड्रेस लिया था मेरे पास से, और उसने बराबर उसने बोला कि जो 2 लोगों का छोड़ के मैंने सबको भेज दिया है। कुरियर वाला यार जरा आराम से भेजता है।
पंकज सर हो गए हैं जो क्वेश्चंस आपने दिए थे ना,
हम्म.
मेजोरिटी फाइनल स्टेज में है.
चलिए बढ़िया सर.
विद इन पीरियड ऑफ 2-3 डेज में आपको भेज देता हूँ.
चलिए दैट्स
जो भी
परफेक्ट.
करेक्शंस है वो.
वंडरफुल वंडरफुल वंडरफुल.
बाकी एक
एक
कल
तो क्या है, गीते सर और माहेश्वरी साहब के एक दिन में 24 नहीं 30 घंटे रहते हैं।
अरे नहीं सर,
कितने
ऐसा
काम निपटाते हो आप लोग?
सर लास्ट टाइम आपने किया तब तो 36 थे सर, 30 कैसे हो गए?
ये देखो।
गीते सर, गुड इवनिंग.
सर गुड इवनिंग सर. गुड इवनिंग सर. एक्चुअली ट्रैवलिंग में था, घर पहुंचा, जस्ट पहुंचा हूं अभी. एक्चुअली ऑफिस बंद करके घर ही पहुंचा था. कल एक केस प्रेजेंट करने का भी सोच रहा हूँ सर वहाँ पे. तो इनिशियली आपको शायद डिस्कस किया होगा मैंने. क्लिनिकली एक 45-50 ईयर ओल्ड लेडी थी, प्रेजेंटेड विथ स्वेलिंग, पेरीयोर्थल स्वेलिंग एंड वाइडिंग सिम्टम्स. तो वेरी सिवियरली टेंडर था एकदम. उंगली रखा तो भी एकदम रोना शुरू कर देती थी. तो क्लिनिकल डायग्नोसिस वाज ये डायवर्टिकुलम. यूरोथल डायवर्टिकुलम क्लोज नेक रहेगा, इन्फेक्टेड रहेगा, ऐसा सोच के हमने प्लान किए। एमआरआई भी किया बाद में। एमआरआई और सोनोग्राफी में अलग अलग डायग्नोसिस, मेजन काइमल ट्यूमर एक ने दिया और एक ने मल्टी मल्टी काय मल्टी नोडुलर मास ऐसा कुछ तो भी दिया।
यूरेट्रोसील निकला क्या?
नहीं सर, वही तो सरप्राइज वही तो। फिर उसके बाद में इंट्राऑपरेटिव जैसा ही ओपन किया, तो उंगली को थोड़ा सा फर्म लगा, इधर उधर से किया तो इन्यूक्लिएट हो गया वो एक 10 सेकंड में। सो ओवरऑल इतना प्लानिंग किया था कि वो डायवर्टिकुलम रहेगा, बड़ा लेंथ रहेगा तो उसको बीएमजी लगाएंगे, छोटा रहा तो क्लोज करेंगे, इन्फेक्टेड रहा तो 2 स्टेज में करेंगे, ऐसा सब समझा समझा के तो 10-15 सेकंड में वो पूरा स्टोरी फ्लॉप हो गया। बाद में उसको क्लोज किया, पेन चला गया।
हाँ,
हिस्टोपैथोलॉजी सरप्राइजिंगली न्यूरोफाइब्रोमा पेरियोर्थल आया, जो कि आप तक रिपोर्टेड ही नहीं।
Oh,
उसका आई से भी किया तो थोड़ा डायग्नोसिस क्लिनिकल से रेडियोलॉजिकल से हिस्टोपैथोलॉजी में अलग हो गया बोल के एक जस्ट सर्जरी, ऐसा कुछ सरप्राइजिंग नहीं है, लेकिन क्लिनिकल एंड हिस्टोपैथोलॉजी में काफी चेंजेस है, इसलिए प्रेजेंट कर रहा हूँ, बाकी कुछ नहीं।
no, very good
I had a similar
presentation.
case. I had a similar case, but it did not get enucleated. I had to resect it, and it came as chronic inflammatory mass, histopathology पे. And now after 3 months, it has recurred again.
ये सर जैसा प्रोस्टेट अपन निकालते हैं ना,
हाँ,
इतना इजीली एकदम वैसा ही सेम नोडुलर आर्डिनोमा इंट्राऑपरेटिवली आर्डिनोमेटस ट्यूमर लगा।
surprising.
तो रिकॉर्डिंग एक्चुअली किया था वो सर्जरी किया, और तो उसकी वजह से थोड़ा सा एक वीडियो प्रेजेंट करने का सोच रहा
Good, good.
नहीं, गुड। ऐसा ही केसेस करेंगे तो दूसरे को समझेगा ना हाउ टू गो अबाउट। एंड नाउ
हूँ।
we don't know, you don't know what how to manage, whether you have to go inside, you have to remove the surrounding tissue, or what you have to do. That is that you'll have to read the literature and you'll have to do the IHC also.
और एक सर शर्मा सर आज केस आया है, पोस्ट डिलीवरी फोर्सेप डिलीवरी है, एंड 11 to 1 o'clock का यूरेथ्रा गायब है कंप्लीट।
Oh,
एंड जैसा भी स्कोप अंदर डाला कि ट्राइगोन पे चला जाता है,
yes.
और एक स्ट्रिप बची है जो ऊपर से ट्रैक किया, तो एक स्ट्रिप बची है जो अभी 1 to 11 के बीच में। अभी उसका कंटेनेंस और ये अभी जस्ट कल परसों ही देखा हूँ, तो हमारा और वो सब चीजें करने का सोचता है। उसको एंटीरियर पोस्टीरियर टैनागो फ्लैप ऐसा कुछ, या फिर कोई कंप्लीट रिप्लेसमेंट ऐसा कुछ तो भी दिमाग में अभी फिक्स तो किया नहीं, देखते।
We can start now.
यस सर, यस सर।
Yeah, so welcome everyone. This is the 5th season we are starting, and we are fortunate to have Dr. G.R. Sharma with us, and he will first give the talk on PU junction obstruction, and then we will have a couple of cases for the discussion. So, Dr. Sharma, please go ahead.
Yeah. Mm. Mm. Yes.
Sir, just welcome all the students and please tell them to be proactive so that this season they benefit maximum. And
Yes.
lot of discussions they can stop and ask sir questions if they want, or clear their doubts so that there is maximum benefit.
Mhm. Right. Good evening, everybody. Thank you, Gaurang sir, Pankaj sir, Hiren sir, and Gite sir for giving me this opportunity to present my views on a topic which is very dear to my heart. It is basically nearly the same talk which I had given for the national board couple of months back, or I think about couple of weeks back. Now, very often we end up using the term UPJ obstruction, but the correct terminology is PUJ obstruction because the urine flows from pelvis to ureter and not the other way around. We all know about the different types of PUJ obstructions, and most often that we are dealing with is congenital or prenatally detected PUJ obstruction. So, What is meant by PUJ obstruction? Basically, as we simply understand, it is failure of urine to pass across the PUJ. And we often say that it is a functional obstruction. So what is meant by a functional obstruction? And this is what I want the students to understand. See, remember the size of the renal pelvis. By and large, the seniors mention it as about 8 to 10 ml. But depending upon the size of the pelvis, whether it is intrarenal, extrarenal, and how compliant it is, it can vary a lot. And unless the renal pelvis is completely filled with urine, it does not contract. And once it contracts after filling up completely, it empties itself into the ureter. Now, when there is an obstruction, so suppose in 1 minute, there are 10 contractions of the pelvis. In a normal patent PUJ, on all 10 occasions, the urine will pass from pelvis into the ureter. But when there is some degree of obstruction, if the obstruction is mild, say out of 10 times, it may pass only 7 to 8 times. If it is severe, it may not pass even more than 1 to 2 times. And depending upon how bad this is, you get the degree of hydronephrosis, which varies from patient to patient. And we all know that this occurs because of an increase in the fibrous tissue at the PUJ, and the spiral musculature at the PUJ is replaced by the longitudinal muscle fibers. And previously, the patients used to present with a lump, UTI, or incidentally detected. But nowadays, the most common way in which the presentation occurs is on account of prenatal detection, and you diagnose antenatal hydronephrosis in 1 to 5% of all pregnancies. So these are the various types of presentations that tend to occur. Either it could be prenatally detected, lump, infection, incidentally detected when ultrasound is done, or there is a details crisis. Now, what is details crisis? It is a condition where a patient experiences pain in the flank along with a palpable lump, and then suddenly the pain disappears, the patient passes a large quantity of urine, and the lump also disappears. Now, this classically occurs when there is an accessory vessel which is crossing the PUJ. It by and large does not occur in typical prenatally detected PUJ obstructions. And as everybody would agree, a prenatally, the details crisis or an accessory vessel which is crossing the PUJ causing an obstruction is usually picked up after adolescence. What are the various ways in which we evaluate? Ultrasound, renogram, MCU in some cases, IVU, which I do at times. But by and large, PUJ obstruction in infants and young children, it is two investigations which are most commonly used. One is sonography and second is a renogram. When is MCU indicated? A child with infection presenting with UTI, if there is an associated dilated ureter, and renal scars seen on sonography. Now, if you read Campbell, even the latest edition mentions that if there is bilateral hydronephrosis, which is of the P3 category, where the AP diameter is more than 30-35 millimeter, they advocate MCU. Now, this is one viewpoint, but there are many pediatric urologists across the world who don't substantiate this particular viewpoint, and they would do an MCU only if the child has a UTI, dilated ureter, or scars are seen on sonography. What is the role of IVU? Rarely done nowadays, and most of the times in children, it's not needed. There is marked use of doing CT urography. But let me be very categorical and emphatic about this fact that by and large, if a good ultrasound is done, the next investigation is a renogram, and CT urography is hardly indicated in infants and children. In fact, it causes a lot of radiation. It is useful only in adults. So the evaluation consists of sonography, renogram, and maybe in couple of years, MR urography will come in a big way to evaluate these children. How do you grade hydronephrosis? And there are different gradings of hydronephrosis. There is a society International Urology Classification, Radiological, Onans, Modified Onans, and AP diameter. And I won't go into the details of this at this particular point of time. You need to remember that on sonography, the AP diameter is best measured because that is having a good objective and inter and intra-observer correlation by measuring the AP diameter within the confines of the renal parenchyma in the axial plane. But the sonologist should also mention about how much is the calyceal dilatation which is present, what is the parenchymal thickness, and in supine and prone, you can get an idea about the drainage of the pelvic calyceal system. Renogram, of course, is the gold standard, and we know that it is now available even in district places. But what we need to remember is that DTPA, because it gives a lot of background activity, should not be used below the age of 2 years. The radionuclide tracer which should be used is either MAC3 or EC. Often MAC3 is not available, so EC is one which is preferred and its results are as good and they are in no way inferior to that of MAC3. Number of protocols have been described: F0, F minus 15, F plus 20, F plus 10. But by and large, F0 is the one which is most commonly preferred. The ideal way to do a renogram is the child should be hydrated with IV fluids. There should be a catheter in bladder. EC or MAC3 should be used as the agent, or F minus 15 or F0 protocol should be used. But often the renograms are not done in an ideal way. 99.9% of the times there is no catheter in the bladder. The child is asked to be fed well. There is no IV fluid which is given, but of course EC and F0 protocol are being followed. Now, how do we diagnose obstruction on a renogram? The simplest way in which people end up diagnosing is that the function is less than 40%. And the other two criteria for obstruction are an obstructed pattern which is seen on a renogram and a T-half more than 20 minutes. So all the students must be aware of these types of drainage curves. The 1, 2, 3A, 3B and 4 types. But you need to remember that these 4 types of curves were described by O'Reilly only when he was following the F plus 20 protocol. Most often when we are using either the F0 or F minus 15 protocol, you get only 3 types of curves: a normal, an obstructed, or an equivocal. You don't get that typical Holmes's sign when you are using an F minus 15 protocol. But I wish to very humbly put forth that drainage curves are not predictive of those patients who need surgical intervention. Even if they are suggestive of so-called obstructed pattern, it doesn't mean that the system is obstructed. And the same holds true for T-half values, because we are often taught that values less than 10 minutes means non-obstructed and more than 20 minutes is obstructed. But there are n number of factors which affect the T-half values. So they are just not indicative of obstruction. The usefulness of T-half value is that if the T-half is less than 10 minutes, it means that the system is not obstructed, and that is pakka, or not non-obstructed. But if it is more than that, then it does not indicate that there is obstruction. And this is why, because there is something called as a reservoir effect. And right at the beginning of my talk, when I discussed the concept of a functional obstruction, this is exactly what happens, that if it is a pelvis which is very compliant and dilated, unless it fills completely, it will not empty. And hence you will get a T-half value which is more than 20 minutes, which is often erroneously labeled as an obstructed pattern. So I want students to remember that good drainage excludes obstruction, but poor drainage does not confirm obstruction. So when we are describing drainage curves or we are describing T-half values, I would suggest that the students end up using the terminology as good drainage, partial drainage, and poor drainage, rather than using non-obstructed and obstructed system. So there are some new concepts about T-half values. In 2021, one paper has described that a T-half of more than 75 minutes or delayed drainage image, where the global washout is less than 50%, that is the drainage from the kidney is less than 50%, is more suggestive, and THAF of less than 5 minutes and a global washout of more than 90% is reassuring. And practically speaking, no radionuclide center waits for 75 minutes. Then people have also described a sitting position for calculating the THAF values, but they are still not practiced universally by all the nuclear medicine centers. So how do we define obstruction on a renogram? See, the three criteria that we initially talked about, out of which two are gone. What remains is decreased function. So if you look at the definition of obstruction, this was first described by Stephen Koff, the person who propagated that prenatally detected hydronephrosis should not be treated as an obstructed system. Because Pankaj sir would agree that the older editions of Bailey and Love also used to define hydronephrosis as dilatation of the pelvic calyceal system due to partial or complete obstruction to the flow of urine. But now hydronephrosis is described as only dilatation of the pelvic calyceal system. And Stephen Koff, by his studies, which he published, showed that you need to define obstruction only if there is impediment to urine flow, which results in loss of function. But are we going to advise wait and watch in all patients? Because Rensley later on found out that if you wait for a very long time, then these kidneys may deteriorate. And then if you operate, they may not return back to the pre-deterioration level. So the biggest problem comes is, how do you identify an obstructed system where the differential renal function is more than 40% before irreversible damage occurs? There are only two ways. Either you keep on doing sonography, which increases, and if there is increase in hydronephrosis, you operate, or you keep on repeating renogram. But this is again a problem of cost, drain on resources, and at times availability of that investigation. So this is what myself and Dr. Pankaj had published in 2012, that if you do sonography and measure the AP diameter in supine and then in prone position, and if it decreases in prone position by more than 10% with no much calyceal dilatation, it indicates good drainage. If the AP diameter increases by more than 10% in prone position with associated increase in the calyceal dilatation, then it indicates poor drainage, and anything in between is partial drainage. You can see one image that on the left hand side, the AP diameter is around nearly 18 millimeter, but in prone position, it comes down to nearly 10 millimeter. Now, once you have this particular idea, so on sonography, you can ascertain that whether there is good partial or poor drainage. And if there is poor or partial drainage, you go for renogram. Now, how do we identify obstruction on a renogram? So there are two aspects. One is we need to establish that there is poor drainage across the PUJ. And second, we need to determine whether this poor drainage is really affecting the renal function. So for this, there are two new things which we need to follow. One is normalized residual activity, and NORA is not something which is new. Dr. Gaurang Shah at his center also has a nuclear medicine department which routinely gives the NORA values. And the second is cortical transit time. Now let us first consider NORA. NORA is basically normalized residual activity. Now what happens is you calculate the uptake values at 60 minutes, divided it by the uptake value at 2 minutes. If the value is less than 0.5, it is good drainage. 0.5 to 1.8 is partial drainage, and more than 1.8 indicates poor drainage. Now, why NORA is better than THAF is because when you are measuring something at 60 minutes, you have taken into consideration the reservoir effect. The child is not lying down on the table for 60 minutes. He is taken up, he is fed, and of course, with the effect of furosemide, he passes urine. And the effect of full bladder, which interferes with bladder emptying, is also negated. So number of articles have said that NORA is definitely better than THAF. I will show you this particular image where if you are given this image, you would definitely say that the left kidney is showing marked retention of the tracer and it indicates that there is possibly obstruction. But if you look at the NORA values here, the NORA value is just 0.263. While in this case, I can tell you that the THAF was more than 35 minutes. And we had published an article regarding the same, which is available in Indian Journal of Urology, September 22 issue. The second concept is regarding the cortical transit time. Now, we all know right from our first MBBS days, and I would recommend students to read the chapter in Campbell from which describes the pathophysiology of obstruction, which mentions that whenever there is an obstructed system, two things happen. The concentrating ability decreases and the excreting ability decreases. Now, we are looking at the concentrating ability by the differential renal function and the excreting ability of the tubules from where the tubules are able to empty into the pelvic calyceal system via the collecting ducts is what is picked up by cortical transit time, which in simple words is the time taken by the radionuclide tracer to travel the cortex. It is calculated from the time the tracer is picked up by the renal parenchyma to the time it appears in the collecting system. And if it is more than 3 minutes, it is considered to be abnormal. So how do we calculate it? Some nuclear medicine centers have got an inbuilt software which calculates the cortical transit time. I am aware of two such centers. One is in AIIMS Delhi and the second is in Jaslok. But Professor Amy Pipses from Belgium had described a visual method because we all get these 1 minute films. So if you look at the upper row, you see that both the kidneys are virtually showing a very darkish appearance by 3 minutes, which means that the cortical transit time is normal in these kidneys. But if you look at the lower row, the right kidney, it is just showing a rim of radionuclide tracer uptake, which by 5 minutes is probably filling up the pelvic calyceal system, and it suggests that there is a deranged cortical transit time. And there are a number of studies which have suggested that this is a very reliable factor. And at times they say that it's the only predictive factor for determining the need for surgery. There is a review article written by us in Indian Journal of Urology. Those interested can go through it. So what's the conclusion? Renogram, always ECU or MEC3, F0 protocol is preferable. Do not diagnose poor flow based on THAF values. IVU and CT IVU are rarely needed. And CTT and NORA can be very useful markers for determining poor flow or obstruction. I will not go through the management algorithm because the new USI book mentions that algorithm. I will just come to few aspects about pyeloplasty. There are different types of pyeloplasty available. And you all know these figures from Campbell, so I won't go in that. But whether RGP should be done prior to pyeloplasty. In children, not as a routine. In adults, at least I do it as a routine because sometimes in adults you can get some surprises. But I would recommend that if you do an RGP, put in a DJ at the same time. Because whatever manipulation you do at the UVJ, subsequently passing even a glide wire can sometimes be difficult. And if at all you don't put a DJ, the UVJ develops some edema and you will have a lot of drain in the post-op period. The basic principles of pyeloplasty are, it should be widely patent, watertight, funnel-shaped and dependent. Use absorbable suture materials. Nephrostomy in pyeloplasty is not indicated as a routine. It is needed only if there is infection, adhesions, and you feel that the pelvic-ureteric anastomosis is under stress. And if you put a stent, then the sequence of removal of tubes is first comes the catheter, periurethral catheter is out if the drain is nil for 24 hours. Then comes the perinephric drain, and then the DJ is removed. What happens if there is persistent drain after pyeloplasty becomes a chapter in itself, so I won't go into the details of the same. But my last thing would be, if at all you end up doing ultrasound after a pyeloplasty, you will invariably again find hydronephrosis, and often the sonologist will report it as a PUJO obstruction, but which is not so. And this is again where you have to look for the epidiameter in supine and prone position and look at cortical transit time and NORA. Right? So what is a successful pyeloplasty? One which has good drainage either on ultrasound and NORA, and one which has better function where the differential renal function has improved by more than 5% or the cortical transit time is better. Thank you.
Yeah, Gnanendra, excellent. I think after your this talk, now when we present the cases, we can use all your information and we can ask the questions. So, Gite sir, you want to add anything or Maheshwari?
Yeah,
Because both of you,
sir.
Dr. Maheshwari has written a paper along with G.R. Sharma. So if he wants to add something, and Gite sir, आपका experience.
नहीं, सर ने तो अभी पूरा इन डेप्थ पूरा डिटेल बता ही दिया है. बाकी बचा तो कुछ है नहीं, तो क्लास क्वेश्चंस लेते हैं सर, बच्चों से प्रेजेंटेशन लेते हैं.
Correct. Bridget?
Yes, sir.
पंकज सर कुछ पूछना चाहते हैं?
I've got one question for you, Ganendra. Hello.
Yes, sir.
Yeah. You see, you said that post pyeloplasty, you looked at improvement in renal function.
Yeah.
You see, in most adults, there is never a significant improvement in renal function. Rather, the only parameter of successful pyeloplasty will be absence of symptoms and no progression of hydronephrosis.
Sir, very
You
true.
see, if the native function was low and in a child, you would expect improvement in renal function, but in most adults, it will not happen. What is your comment?
Sir, perfectly correct observation. And this has been described in a lot of papers also. To an extent, I would say that even in children, if the function is very low and the cortical transit time is nearly normal, you do a pyeloplasty, the function does not improve. The first paper which was published in 2008 was by Schultman, and he said that unless the cortical transit time is deranged, these kidneys don't improve. And I had at least 2 cases by personal communication with Professor Amy Pipsis, and she had sent me the renogram images where the child at 1 year had 18% function. And she had asked the pediatric urologist, don't operate, the function will not improve. And after 4 years of follow-up also, the function was 18% only. So this happens. And in most of the cases, as you rightly said, in adults, the function is nearly the same. You have to look at either NORA or absence of symptoms or decreased hydronephrosis. But interestingly, the decrease in hydronephrosis on ultrasound is again very fluctuating. Somebody does a good reductive pyeloplasty. Within the first 3 months, you find, arey, bahut achhi kidney hai. They come back after 3 years and you will find a significant dilatation of the pelvis again.
So in adult, the only criteria for failure will be recurrence of symptoms.
Recurrence of symptoms, infection or deterioration of function. Initially
Most often-
25%,
most often we do not-
25% and it comes down to 15%. It definitely means that the system is obstructed.
Fine. So another thing which I want to say is that when we are doing pyeloplasty, I feel that the leakage can take place up to 4 days. So normally what I do is I keep the drain for at least 4 days and then remove the Foley's catheter. What is your view on that?
So basically in children below the age of 5 years, I don't put a DJ at all. And in most of them, I don't put a catheter also. So I only have only one tube which is drain. But if you have put in a DJ, I would wait till the drain is 0 for 24 hours, remove the catheter first. If reflux, still there is no drain, then I remove the drain. And lastly, the DJ comes out after 4 to 6 weeks.
No. But when you remove the Foley's catheter, on the second day, third day or fourth day?
No, sir. There is nothing like fixed. I keep it minimum for 48 hours. If at all, if I have kept a DJ in an adult, after 48 hours, I know that there is no drain, I remove it. So there should be minimal drain or no drain for 48 hours, for 24 hours and I remove it. That's it.
In fact, in adult pyeloplasty, we always counsel the patients that there may not be any, markedly improvement in the function. It will be just a stabilized function, like Pankaj sir said. So that was a very important point.
सर, as far as फंक्शन का डिस्कशन चल रहा है तो फंक्शन का ऐसा कुछ फिक्स नहीं है सर. सम पीपल इट विल इम्प्रूव, some people it will static, and in some people it will deteriorate.
Go down.
Usually in older children, why function doesn't improve is the compensatory hypertrophy of opposite side kidney doesn't allow to regain the function. That is one. And recurrent infection in till older age, which will another cause for not recovery of the function. These are the two important reasons why there is no improvement in older children, and in early age it will definitely improve.
Fine.
Perfect, sir.
Brijesh, can you start your presentation? And who is answering today?
Sir, Dr. Soliraj Ekans and Dr. Amarnath.
Okay.
Hello.